Forward, okay. Hi, everybody. It's nice to see some familiar faces in the room. I am going to be your professor of Meso 101 today. We're going to be talking about the basics, hints and tips to help you better understand the medical terminology and language that will be used throughout this conference. So here we go. All right, so meso. There are 3 different cell types or histology, and this is based on the appearance of the particular cells. So you get your biopsy, the pathologist actually looks at the cells underneath the microscope, and he or she will then tell us what the cells look like. There is epithelioid, sarcomatoid, and then biphasic or mixed. So epithelioid is the most common type. It is about 50 to 70% of all cases. It tends to respond better to treatment. Sarcomatoid occurs in about 7 to 20% of all cases. This is more aggressive and more resistant to treatment. Biphasic or mixed is about 20 to 30% of cases, and this is a combination of both epithelioid and sarcomatoid. And the pathology reports may actually give you a percentage of which is the more dominant histology. Let's talk about staging. So typically we use the TNM system, so tumor node metastasis, and this helps us figure out if the cancer is phase 1, 2, 3, 4, right? Stage 1, 2, 3, 4. So tumor indicates the size of the tumor or deeper tissue involvement. Node indicates regional versus distant lymph node involvement. And metastasis indicates if the meso has spread outside of that primary region. So together, you all get a TNM staging, which then basically gives us whether it's a 1, 2, 3, or 4. For peritoneal, you might actually see a PCI, or a peritoneal cancer index, which is a score that's calculated by giving each of the 13 abdominal regions a score from 0 to 3. 0 being no tumor, 3 being the tumor greater than 5 centimeters. They add it all up together, and so a higher score indicates that there's more widespread or larger tumors. Once we have the stage and the histology, that then drives the treatment plan, right? So if you are a stage 1 epithelioid, perhaps surgery would be the right next step. If you're a stage 4 sarcomatoid, maybe a systemic treatment would be the right next step. Make sense? Okay. So let's talk about surgery. In terms of plural, PD is pleurectomy decortication. This is a lung-sparing surgery. So the surgeon will go in and remove just the pleura or the lining of the lung, but they leave the lung intact. EPP is extrapleural pneumonectomy, which means they actually remove the entire impacted lung, the pleura, and all the structures around it. For peritoneal, you'll see cytoreductive or debulking surgery. Cytoreductive is also CRS. After cytoreductive surgery, there are 2 different ways that we can give intraperitoneal chemo. One is called EPIC, and the other one is HIPEC. Now, EPIC stands for early postoperative intraperitoneal chemotherapy. During the surgery, they typically put in a port, and about 6 to 8 weeks after surgery, we start to instill the chemo. HIPEC is hyperthermic intraperitoneal chemo, and basically when you're in the OR, they directly instill the chemotherapy into the open cavity. Okay. So in regards to systemic therapy, that means treatment that goes through the whole system. So this is supposed to get any cancer cell wherever it might be. So your medical oncologist will choose the best therapy based on what we talked about already, staging, histology, and if you have identified mutations, which I will get to in a few slides. So there's a couple of different ways that we can go. There's chemotherapy, which is cytotoxic, and it stops the growth of rapidly dividing cells. There's immunotherapy or immune checkpoint inhibitors, where we actually harness the body's own immune system to fight the cancer. Precision medicine is a personalized medicine based on the tumor's morphology. And then targeted therapies is actually a type of precision medicine where it actually targets a specific protein on the cancer cells. Systemic treatment can be given in a whole number of combinations. It can be given in a whole different number of patterns. So let's talk about the way it can be given. So adjuvant treatment is given after surgery. The goal is to reduce the risk of recurrence of disease. So an example is surgery followed by adjuvant chemotherapy. Neoadjuvant is given before surgery. It can also be called induction therapy. The goal is to make sure that the surgery is more likely to be successful. An example of this, in your notes, you might see neoadjuvant chemotherapy. Multimodality treatment is combination therapy. So if you get chemo, surgery, and radiation, that would be multimodality treatment. It can also be used to talk about combination treatment. So in some cases, people will get a combo of both chemo and immunotherapy. I wanted to use the word IO here to show that IO is a shorthand way for writing immunotherapy, if you see that in any of the presentations today. In regards to lines of therapy, this talks about the treatments themselves. So the first chemotherapy that you ever get, or the first systemic treatment, I should say, is your first line. The next one is your second, et cetera, et cetera. You might see 1L noted. That's shorthand for first line. Another way that we can target cancer is through radiation. So external beam radiation therapy is a non-invasive radiation beam that focuses specifically on one part of the body. This can be given in multiple different ways. There's photons, there's protons, there's a whole slew of things above my pay grade. But there's also IGRT, which is image-guided radiation therapy. There's IMRT, intensity modulated radiation therapy, and SBRT, stereotactic body radiation. And clearly I spelled therapy wrong there. Sorry about that. There's also TTF, or tumor treating fields. An example of this is NovoCure or Optune. And basically this uses electric fields to exert forces right on the cancer. So think like microwave ablation, high frequency electric fields, things along those lines. Okay, clinical trials. So clinical trials are actually also known as research protocols. We kind of use the terms interchangeably, so you might see that. An objective of a clinical trial is the question, the why. Why are we doing this study? What are we looking for? Methodology is about how we're going to execute the trial. Desired outcomes and endpoints is basically what is the most relevant answer to the question, right? What's the question we are trying to answer? There's a whole bunch of alphabet soup that comes along with clinical trials and some of the research. So OS, PFS, ORR, CR, PR. OS is overall survival. PFS, progression-free survival, so how long people go without the cancer growing. ORR is overall response rate, so in totality, how many people responded. CR is a complete response, meaning can't see the cancer on the scans anymore. And PR is partial response, meaning that the cancer shrunk but is not completely gone. Many clinical trials will have arms, meaning that participants are divided into specific groups within the trial. So think Arm A will get drug 1, Arm B will get drug 1 and 2, and that clinical trial might be wondering if addition of drug 2 helps drug 1 be more effective, okay? I get a lot of questions about placebos when I'm talking about clinical trials, so I just thought I'd take the opportunity. It's unethical to do a trial where people only get placebo, right? So you're never going to see a study where arm 1 gets drug 1 and arm 2 gets placebo. What you might see is that both arm 1 and 2 get drug 1, but then that first drug might be a combination with the placebo versus drug 2. Does that make sense? And then again, it's a question of, did drug 2 help drug 1 be more effective? Clinical trials can also be randomized or non-randomized. So randomized is a trial in which the participants are divided at random into separate groups. There's literally a computer in the back that just spits out which group you're going to go into. And sometimes this is blinded, which means that your clinical team actually does not know if you are getting drug 1 or drug 2. It's all basically like on the computer. Non-randomized is a trial in which participants are actually specifically allocated into an intervention based on controlled methods. So if you have this mutation, then you go here. If you have this mutation, you go there. Clinical trials have 4 phases. Phase 1 is early phase, and this is when they're basically just evaluating safety and tolerability. So like if we give you a medicine, is it safe? Is it going to cause harm? And can you tolerate it? Phase 2 then takes the medicine and gives it to more people and checks for effectiveness and safety. Phase 3 then compares that medicine to standard of care. So is this better than what we already have or not? And then phase 4 comes after approval, and this is basically when you're evaluating the medicine like in real life, right? You're giving it to a lot more people, you're looking at it for longer term effects, and you're seeing more potentially rare side effects. So now we're going to talk about genetics and mutations. So this can get a little confusing. Germline mutations are inherited from your parents at conception. Examples are BRCA1, 2, Lynch syndrome, cystic fibrosis. So you get this from mom, you get this from dad, you share it with your siblings, you could potentially give it to your children. Somatic mutations are genomic alterations that happen after conception. So examples are HER2, ALK, EGFR, BRAF. This is the mutations within your cancer cells. It is not something that you get from mom and dad. It's not something that you can pass on to your kids. Next-gen sequencing, or NGS, actually looks at these somatic mutations. So I'm sure a lot of you guys have had Foundation 1 or Guardant 360 run on your tumors. This can be done in multiple ways. They're tissue, blood, and saliva. So tissue is actually looking at the cancer cells themselves. And then blood and saliva, sometimes we can actually pick up the DNA of the cancer within your blood or saliva, and then actually we would be able to forego an invasive biopsy. If on the next-gen sequencing you have alterations, mutations, things along those lines, that actually might lead you to be able to get clinical trials, and it's going to be where most of the clinicians are focused on for new and emerging treatments. And then lastly, once you have your NGS testing, your clinician might offer things such as novel therapies and gene therapies. Novel therapies is personalized medicine, so it's going to be targeting a specific protein or mutation within your cancer cells. And in doing so, if your cancer cell is the only thing that has that mutation, it will spare the healthy cells around it. Gene therapy is an emerging area, and this actually is an alteration of the genes, and this can be done through immunotherapy, viral therapy, and gene transfers. That's all I have. Hopefully I didn't go through that too quickly. Any questions? All right, if anything comes up the next day or so, I'm around, so feel free to just come up, introduce yourself, and I'd be happy to answer your question.